Joining us today. We are recording this event and the slides will be available in the next few days along with the recording. Good afternoon. Thank you so much for joining us. My name is Karadina Sale with the Community Technical Assistance Center, and I would like to welcome you to today's webinar to talk about the complexities about complex trauma. Complex trauma, as I'm sure you know a little bit about, some of us more than others. It's a relatively new term, not that new to the people presenting, obviously, but this is new language around trauma that I think is incredibly important, an incredibly important topic. And today our presentation will really be about understanding the impact of complex trauma on youth and families and enhancing the trauma-informed awareness and practices across systems. And it's being presented by two amazing people in the field, Dr. Cassandra Cassell and Patricia Garibaldi. Before we get started, I want to just take a moment to orient you to everyone to the Zoom. If you haven't been here before, if you have, I'm sorry that this is a repeat, but just note that everyone who's joining, you've been placed on mute to avoid any background noises. If you come across any technical issues, please chat to our host, Phuong Tran, who will be able to assist you. We are going to have a Q&A at the end, so you can chat in your questions along the way, or you can save them for later, but the earlier the better. We'll be collecting questions throughout the presentation, okay? Once again, thank you so much for joining us. And we're just so grateful for Dr. Cassandra Cassell, whom I had the opportunity of learning about her work several years ago when I was first delving into the topic of complex trauma. And Dr. Cassell, you've been such a great colleague, and I appreciate all the work you and your center are doing. She's a clinical psychologist and associate director within the Mental Health Services and Policy Program in the Department of Psychiatry and Behavioral Sciences at Northwestern University Feinberg School of Medicine. She is the principal investigator and director for the Center of Child Trauma Assessment Services and Systems Integration, a longstanding federally funded center of the National Child Traumatic Stress Network, also known as NCTSN, that specializes in supporting child-serving systems and developing the infrastructure to understand, assess, and respond to the complex developmental effects of childhood trauma. Dr. Cassell is recognized for her expertise in the area of child trauma assessment, and with her extensive experience in supporting the implementation of trauma-informed practices within the NCTSN, including a range of intervention approaches and assessment strategies with practitioners across the country. Patricia Garibaldi is a doctoral candidate at Northwestern University Feinberg School of Medicine's clinical psychology program, working with doctors Cassandra Cassell and Neil Jordan at the Mental Health Services and Policy Program. She helps facilitate trauma-informed care trainings and supports data management for residential providers within the Illinois Department of Children and Family Services. Patricia also supports the works of Dr. Cassell's Center for Child Trauma Assessment Services and Systems Integration. Patricia has worked as a frontline mental health provider for youth in acute residential care and has prior research experience examining transdiagnostic evidence-based treatments in community mental health and school settings. I'll now pass it along to our presenters to get us started, and thanks again so much for being here, everyone.
Thank you, Kara, and welcome everyone. Thank you so much for joining today. I'll just say another quick word. I think Kara summarized what we're doing pretty well, but we're very excited to be here. I'm excited to be here with my colleague, Patricia, and we are going to be talking a lot about our work through that we've been doing as a part of our NCTSN Center. And as Kara said, we have been fortunate to be a part of the NCTSN for 11 years now, going on another funding cycle actually as of this week. So we're really excited. This is great timing to kick us off in our new funding cycle. Patricia, anything more you want to say before we dive in?
No, I think that you've covered it.
Okay, so Patricia, if you wouldn't mind going to the next slide. So what we want to start by doing, I know there are many of you on the webinar, which we're excited to see, but if I was in the room with you and in any webinar, I always like to know who's in the room to get a little bit of information. So if you wouldn't mind completing this poll that I think should show up for you as far as what service settings you work in, and you can check more than one. Oh, sorry, it's a single choice. But I'm guessing most of you are behavioral health, but if any of you are primarily in other settings, please let us know. So as you're doing that, we'll give you a couple of seconds. And yeah, thank you. And feel free to type in the chat as well as you're completing that. And Patricia, if you wouldn't mind, as folks are completing that, I just want to put up the learning objectives. And then maybe after I go over these, we can feedback in who's in the room. But just to kind of give you a sense of what we want to cover today, we have a lot of material. And one of the things, if any of you have heard anybody on our team present, we tend to have a lot of rich information, or we try to. It's pretty comprehensive. So what we want to do is a combination of sharing some information of what is complex trauma, what does it look like across development, what are some of the relevant diagnostic and clinical issues related to work across child serving systems, behavioral health, and child welfare, juvenile justice, which are the primary systems in which we work. We want to share some video resources because we really think these bring some of these issues to life. And these are resources that we've actually worked to develop as part of our NCTSN grants. And then we want to talk a bit about effective practices, trauma-informed practices for working with youth and families, for providers within behavioral health settings, as well as across various systems. So it looks, thank you for completing the poll. So it looks like the majority are behavioral health providers, with some in child welfare schools and a little bit in legal, but thank you for completing that. I appreciate that. So if you wouldn't mind going to the next slide, Patricia. So as Kara mentioned, we've been a part of the NCTSN, but I just want to acknowledge how important the NCTSN has been to our work. It's a congressionally established initiative that's been around for now 30 years. And it's focused on raising the standard of care and improving access to services for children and families across the country. Here is the website. If you haven't checked it out, I would really encourage you to do so, because there's a lot of wonderful training resources for working with youth and families across service settings, across different age groups. And so it's been a great resource and responsive to a lot of the things that have unfortunately been happening in our country across the last many years, and in the context of the pandemic as well. So there's a lot of wonderful resources to check out. So the next slide, please. And this is just a bit about our center. So our CTASI is what we like to affectionately call it, but the Center for Child Trauma Assessment Services and Systems Integration is our actually newly rebranded name. But we work primarily within behavioral health, but also within child welfare and juvenile justice. And child welfare and juvenile justice are actually our primary focus within the current grant cycle. And our emphasis is really around responding to the complex developmental effects of trauma. We've always focused on complex trauma in our work, and we're entering our fourth funding cycle now, and that's been a big emphasis of our work in terms of training, dissemination, and product development in those areas. We also have been doing a lot more work around systems transformation, so working in a more targeted way within child welfare and juvenile justice systems to support trauma-informed services, and then doing some more of that coordination, because we know many youth are dually involved or multiply involved across systems. So focusing on cross systems coordination, and responding to systemic trauma in particular. That's an area of focus that we've been really trying to hone in on for the last couple of years, as we focus on the impact of systemic trauma and racism, which is unfortunately impacting many youth. And we know it's a big part of complex trauma as well. And then finally, responding to the unique needs of subpopulations. So in particular, multi-system involved youth, transition age youth, immigrant refugee youth. And so those are some of the areas that we're going to continue to hone in on more fully. So if you wouldn't mind going to the next slide, Patricia, which I think is, is you.
Yeah, so before we dive into some more of the main content, we'd love to hear from you all about if you've ever had any training before on childhood trauma or complex trauma. So again, we'll just give a few moments for folks to complete that poll. Great. So as more people are answering the question, we'll dive into the kind of meat of the content here. So we're going to be talking about childhood trauma and complex trauma across child serving systems. And before we so it looks like, okay, the majority of you have had some training on trauma, which is wonderful. So we're hoping to, add to your knowledge base here. So before we get into it, let's really zoom out and first discuss what we talk about when we talk about trauma. So the traumatic event itself is really only one component of trauma. So we think about trauma using SAMHSA's federally established definition, which includes its 3 E's. So the first E, the event or series of events or set of circumstances that is then experienced by an individual as physically or emotionally harmful or life-threatening. and then has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So we really think it's critical to think about how an individual's identity and different groups that they may or may not belong to can impact the events that they may be more likely to be exposed to and the ways that they might experience the events that they are exposed to. So this means that two people can go through the same event and have different experiences of it and feel different effects of it. For example, two people might be in the same car accident, in the same car, and it might be traumatic for one person, but might not be traumatic for the other person. So we also really want to think about really distinguishing the stress from trauma. So we can think about stress as any challenge or condition which forces our regulating physiological and neurophysiologic systems to move outside of their normal dynamic activity, whereas traumatic stress might be an extreme version of that stress. So as we all know in the field, this word trauma has become really commonly used and a popular term in kind of everyday language. But from a mental health perspective, the term trauma has a very specific meaning, and it's different from what we think about as normal stress. So all human beings experience stress. It's a normal part of life. And it's normal for stress to impact our physiology, to cause tension or headaches or stomach aches, and to impact the ways that we think and the ways that we act. And while we all experience stress, only a subset of people will experience what we think of as traumatic stress. There is a difference between normal stress and extreme or traumatic stress. And like I gave the example before of the car accident, an event that's stressful for one person might be traumatic for another person. The following slides are going to provide a little bit more detail on this distinguishment between stress and trauma. So this slide lists some events that might not be traumatic, but are still highly stressful and can temporarily disrupt functioning. So these might include the death of an elderly loved one, divorce, job loss, moving, an acute illness, or test or performance review. So these are things that might typically be very stressful, but often not traumatic. Of course, it's possible that one of these events could be experienced as traumatic by an individual. For example, a particularly adversarial divorce. And this slide lists a range of situations or events that can be considered traumatic. So some of these might include a single episode, so something that happens only at one time, while others might be more chronic or ongoing. The nature of the event can impact how the events are experienced and the effects that it has on the child and the family system. So the events listed on this slide are based on what the NCTSN has outlined as some commonly occurring events that are often experienced as traumatic for folks. So they include neglect, abuse, sudden or unexpected death, domestic violence, serious accidents, community violence, system involvement or caregiver separations, terrorism or violence, disasters, refugee trauma, life-threatening illness, or identity-based violence and racial trauma. And of note, while COVID is not explicitly listed on this slide, it can very much be thought of as belonging to the category of disasters. COVID in and of itself has likely been a stressor for almost all of us. And depending on the individual's experience of it and the effects that it may have had on them, it could surpass being a stressor and get into that realm of traumatic stress. In fact, just today, there was a study published in the Journal of Pediatrics that found that between April 1st of 2020 and July 30th of 2021, over 140,000 children in the US have experienced the loss of a parent or grandparent caregiver, with this rate being 4.5 times higher for groups that have been minoritized based on their racial or ethnic identity. So this is just kind of one piece of this COVID trauma puzzle that gives us an idea that COVID has likely been very traumatic for a lot of the youth in our country and a lot of the youth that we might have contact with in our settings. So now I'll pass it back over to Cassie.
Thank you, Patricia. And one of the things, as we're getting started in this section, I just want to kind of ask you all to maybe impromptu chat this question, because I know we had asked you in the beginning what your primary service system is that you work in. But if you wouldn't mind sharing with us, if you work with kids who are involved in multiple systems, so outside of schools, for instance, do you work with youth who are both involved in the behavioral health, mental health system, as well as the child welfare or juvenile justice, who are dually involved in child welfare, juvenile justice? So do you work with multiple systems? Because that's one of the things that we do know. So if you work primarily in the mental health, behavioral health system, you likely also see young people who are child welfare involved, or potentially have been juvenile justice involved. And so one of the things that we do know, because a lot of our work is focused on cross systems work, is that that trauma shows up across all systems regardless. So we talk about it in terms of the large majority of the high rates of trauma within child welfare and juvenile justice, which I'll talk about in a minute. But we do know that trauma is a common theme across systems, unfortunately. So that's why it's important for us to understand. And as providers, I think one of our key roles is to really work around advocating for trauma-informed services, educating one another about trauma-informed services, because it is so critical. And unfortunately, not all systems have the same access to these kinds of resources and training. So that's one of the things we're trying to promote. So Patricia, as I go into the next slide, if you wouldn't mind changing it, I don't know if you've seen in the chat, it looks like people say multiple.
Yeah, it looks like a lot of folks are saying that they work with youth who are involved in a lot of different systems.
Okay, and so just to give you a bit of context, Patricia just talked about the rates of what is trauma. And so as we understand youth and child welfare and juvenile justice in particular, we do know that rates of trauma in particular are higher in those systems. And I don't know if anybody wants to make a guesstimate in the chat about what percentage of youth involved in child welfare or juvenile justice are impacted by one or multiple traumas. I won't answer that question yet. I'll wait a minute to see if anybody wants to respond to that. But one of the things that we know is that many youth with trauma histories in current systems are never fully assessed. And I do see, right, 90, you're absolutely right. So those rates are based on current studies anywhere between like 92 and 97% have at least one trauma. But we know the reality is that many of these youth have multiple traumas that they've faced as they're coming into the system. And then unfortunately, when they're in the system, there's also the potential to face additional traumas and additional stressors, unfortunately. So the importance of trauma-informed practices within those systems, within any system, is critical. But unfortunately, as I started to say before, many youth and adults who are in these systems are never fully assessed or assessed at all. And what I mean by that is they may have an assessment, but one of the things we know is that those assessments are not always trauma-informed. They may get a behavioral health assessment. They may receive an assessment that's more limited, because we do know that at times is a challenge, right? There's a lot of different demands upon providers' time. But as a result, if the assessment themselves are not trauma-informed, then those dots are not connected to providing services that are trauma-informed. And so unfortunately, those youth receive a lot of labels, receive a lot of diagnoses, but they're not necessarily being treated or served through that trauma-informed lens. So that's why assessment and screening are so critical in this process. The other thing that we know is that, unfortunately, within some of these systems, youth, especially when providers don't have a trauma-informed lens or knowledge about trauma, they're sometimes blamed or labeled as bad kids or troubled kids. And unfortunately, that's still the case, and we can see how that unfortunately might be the case for youth entering into the juvenile justice system in particular, with, committing offenses, criminal offenses. But oftentimes there's a reason for that, right? So that's the thing we're trying to understand, is what are some of those things prompting those services. And while youth do receive and need to receive appropriate consequences, those consequences can be shaped using a trauma-informed lens. So we've seen some really great work around that happening. So we're really advocating for a broader understanding of how do you understand those behaviors that can often be troubling or quote labeled as bad as perhaps attempts to manage or regulate trauma reactions. So a lot of the reactions that we can see can be understood through a trauma lens and addressed in more effective ways that really serve the youth and support the youth. So that's some of the work we're trying to do. And then finally, unfortunately, the thing I wanted to note is that oftentimes these youth coming into these systems, child welfare and juvenile justice, are comprised of largely oppressed individuals. So they're oftentimes coming, they're coming from backgrounds or communities where there are a lot of ongoing stressors which they face. And youth of color are unfortunately overrepresented in these systems as well. So, and there's additional layers of stress and trauma that can accompany that as well. So those are so important things to keep in mind when we understand the backdrop of complex trauma. Okay, next slide. Patricia, are there any things to factor in from the chat that you can think of?
No, just one person's comment that thinking about 100% of youth in care is experiencing trauma because being in care itself is traumatic.
Exactly, exactly. And that's a great point. In fact, one of the things that some of our trauma colleagues, and we've done this as well in some of our work around assessment, is that coming into care and separation from caregivers, placement disruption is can be a traumatic event in and of itself. So that's an important piece too. And then that being placed into care, right, and removed from one's caregivers can be a trauma. So yeah, thank you for that. So on that note, that's a good link to this next slide. So one of the things that we did, I just want to share, we've been fortunate to partner with the child welfare system in Illinois for decades at this point. And this is a study that we published several years ago now, but I think it's compelling in that what this talks about is complex trauma in a different way. So we looked at, kids who have exposure to both the typical kinds of trauma that Patricia mentioned around the acts of what we call the acts of commission. So the physical abuse, sexual abuse, exposure to domestic violence as the kind of more violent types of trauma. And then also those kids who are exposed to more of those acts of what we might call omission, so neglect, emotional abuse. And sometimes in some systems, those were not always recognized as like the big traumas, but we know they can have a significant impact. And we know that they can, in fact, impact the youth in different ways. And in fact, sometimes more pronounced ways than those bigger T's, those bigger traumatic events. And so what this slide shows us is for those youth in that second bar, for those youth who have exposure to, even if it's just one type of trauma, neglect or emotional abuse, they're 15% more likely to have a placement disruption compared to youth who don't have those experiences. And that's higher than those youth who just have that exposure to a violent type of trauma, a physical abuse or a sexual abuse. However, when we see youth who have more of that complex trauma profile with both neglect and physical abuse or sexual abuse or exposure to domestic violence, they're over 25% more likely to have a disruption in their placement while in care. And we know that disruption in placement is traumatic. So what are all those things contributing to that? This does not talk about the responses, but we know that having that complex trauma can relate to a lot of different types of complicated reactions, which unfortunately, if a caregiver at home doesn't have the resources to manage and support that, that can lead to placement disruption, which we know can become even more traumatic. So that's just to kind of paint that picture there. So Patricia, if you wouldn't mind going to the next slide, I'm going to quickly talk about how, I'm just going to see how we're doing on time here. Okay, so I'm going to quickly just talk about some trauma reactions. Then I'm going to show you a short video that just kind of that moves it off the list. And thank you. I just see that comment about racial trauma. Yes, that I appreciate you saying that racial trauma is not on the list. This, as you can see, this study we published was almost a decade ago, and our thinking has certainly changed, and our resources and even the NCTSN, I have to say, they have shifted in their thinking. And I'd say that's really a big response to the unfortunate events of racial injustice that have happened in our country over the last 12 to 18 months. And I know the NCTSN has made a big push to really talk about how anti-racist practice is critical to trauma-informed practice. But the reality is that wasn't always the case, that we were talking about those things simultaneously, and now we really are. So some of our earlier work isn't going to be reflective of that, unfortunately, but I appreciate your comment there. So just quickly on PTSD. So this is what how youth can respond to trauma. These are the different categories of response for post-traumatic stress disorder. So we know that there are 4 categories of traumatic reactions associated with the PTSD diagnosis, including re-experiencing reenactment, so those intrusive kinds of symptoms, avoidance of cues associated with trauma, so avoidance of reminders, triggers, places, negative alterations in cognition and mood, and then more of that hyperarousal, hyperreactivity that we see in terms of like sleep sleep problem, hypervigilance, scanning the environment for danger. So we know that's an important diagnosis, but we know there are limitations to that diagnosis. So this diagnosis was originally created in the 70s, and it was really in response to Vietnam veterans and their responses. And I have to say, there have been a lot of improvements in the diagnosis since in response to youth. But one of the main criticisms of this diagnosis is it doesn't really capture what we often see in our kids. And so Patricia, if you wouldn't mind going to the next slide. And so that's how many of our youth respond to trauma. If you take a look at this list real quickly, just do a scan. If these reactions look familiar to you, please put those in the chat. And these are all very common reactions: inability to trust, difficulty with relationships, difficulty accepting support, highly physically or emotionally reactive, difficulty calming down, often aggressive, angry outbursts, aggressive outbursts, difficulty problem solving, making the same mistakes over and over again, difficulty processing information or learning. So if you wouldn't mind going to the next slide, Patricia. So this is what we often see as complex trauma. So when we talk about complex trauma, this term has been around for a while. I want to say kind of a good 20 years, but not everybody understands what it is. And so just to kind of define it so we're all on the same page, it really refers to a combination of both exposure and adaptation or trauma responses. So oftentimes what we look at with complex trauma are those youth who are exposed to multiple chronic traumas that we've been talking about that are often interpersonal in nature. So physical abuse, sexual abuse, emotional abuse, neglect, those are kind of the big five. And then and racial trauma. I think you're absolutely right. We need to redefine our definition of complex trauma. And we've been starting to talk about it. But again, let me just note that this is our earlier definition where we didn't have all of those things incorporated. But the key here is that the traumas are interpersonal in nature, and they're often starting at a very young age, because we know that there's something that can happen developmentally in terms of derailment when a caregiver, somebody who's in charge of your care, is the perpetrator of trauma. And we know that can really shift your responses in a way that's different when a trauma is not interpersonal nature. And the fact that it happens at an early age also has a significant impact. So there's been a lot of studies, a lot of work that's been done to look at the primary domains of impact, which are listed here. And Patricia, if you wouldn't mind going to the next slide. And the next slide really spells them out in terms of these are the key developmental deficits across those 7 areas. So things that we've been talking about in terms of difficulty regulating emotions, difficulty with the behavioral control, oftentimes impulsive behaviors and outbursts at kind of and something that can shift them. You may have heard people say, like, it can be a 180 at the drop of a hat. Something happens that triggers them. So there's an impulsive reaction or a quote unquote outburst. Difficulty forming close relationships or attachments, difficulty with social functioning, difficulty connecting with their peers, either physiological overarousal or underarousal, somatic complaints. It can come out in those kinds of ways. Problems with learning and attention and concentration and cognition. Dissociation and numbing. This is an area that I've done a lot of work in, and this is not just dissociation in the sense of, dissociative identity disorder, but we can see it in terms of, the spacing out, the shutting down, the kind of forgetfulness, the frequent forgetfulness, derealization, things that may look like psychotic-like symptoms, what are in fact dissociation. So dissociation is a really nuanced area that there's been a lot more work done recently in terms of understanding it in youth. And then finally, poor self-concept, a damaged sense of oneself, negative beliefs about oneself. And so these are some of the areas that have been associated with complex trauma as part of this framework. And then Patricia, if you wouldn't mind going to the next slide. And for those, one of the questions I didn't ask was how many of you work with young kids or adolescents, but these are some of the different ways they might manifest across development. And I'm not going to go through these in detail, but just to call a couple of them out. So in toddlers or preschool age kids, you may see more problems with anxiety, difficulty attaching, difficulty forming attachments with your caregivers, with your teachers, problems with separation. So when dropping them off at daycare or or preschool, really either having an intense fear more than normal, or having an overly easy time. Doesn't seem developmentally appropriate, having a lot of stranger anxiety, a lot of reenactment, a lot of things coming out in terms of their play. In school age kids, we may see more of those somatic complaints, more difficulties with attention, concentration when they're in school, focus. May see some more of that dissociation come out in terms of numbing or spacing out, more relationship disorder. As the relationships become a little more developed, they, having difficulty connecting or forming consistent peers. And in adolescence, we may see more of that, those impulsive behaviors, the angry outbursts, more alienation from peers, really challenging authority. And these are, I have 2 teenagers, I have to say, so I know some of these are common responses, but when you see them in a way that is that is a bit more troubling or difficulty to bring them back to baseline, that happen consistently or seem to be triggered. And I don't want to paint the picture that, because there are a lot of things in here, that if you see a youth in this category, that means they're traumatized. It doesn't mean that, but this really helps just to think about in a more thoughtful way that if you're seeing a youth that may not have those PTSD symptoms, but have these kinds of symptoms, that this may in fact be complex trauma. If you know they have a significant trauma history and you see these kinds of responses, just be curious as a provider to say, these may be connected back to the trauma. These may be a reaction, because these are often common reactions that we see in this complex trauma profile. So I know we're getting short on time. I think we might have the video coming up next, Patricia, if I'm not mistaken. Okay, perfect. So one of the things we want to do is just pause here. We've done a lot of work around developing resources to support awareness around complex trauma. So we're going to show you a couple of clips today, starting with this one that really talks about this overview of complex trauma and using, I think I'm saying some things, so it's going to be myself in this video, a psychiatrist who we partnered with as well, Catherine Scott, and my other colleague who's also a psychologist, Mandy Habib, I believe, are featured in this first clip.
Children and adolescents who have experienced chronic or multiple traumas, beginning at an early age and often at the hands of their caregivers, really often have a range of difficulties, a range of significant difficulties that cut across areas of functioning and impairment and across different diagnoses. And this is often referred to as complex trauma. Unfortunately, the challenge is that there is no one diagnosis to identify kids who have been complexly traumatized and who have complex trauma symptoms. Trauma doesn't just look like one thing, but it looks like a lot of different things, and it may lead to a range of different labels that are not connected to trauma. And so what this means is that a lot of the youth that are served often do receive multiple diagnoses.
I think of trauma as the great imitator. The effects of trauma can look like depression, they can look like ADHD, they can look like bipolar disorder. In some cases, they can even look like schizophrenia. We may see someone who comes in with depression and anxiety and panic attacks and mood swings and some aggression. And you could give each of those behaviors a different diagnosis, or you could say, what explains all of it? And especially in children, maybe all of those things are explained by a trauma history. So the term complex trauma has been used to try to get a handle of this, that trauma is not just one simple little thing, it's not one diagnosis, but it can involve so many other things. It can involve people's relationships, it can involve being aggressive, it can involve being very depressed, a whole bunch of different ways that are much larger than one particular diagnosis.
What I often see in my work is that children who have experienced trauma are often misdiagnosed with an autism spectrum disorder, ADHD, and a lot of it has to do with the fact that sometimes there isn't a comprehensive enough history taken related to the child's experiences. Having experienced trauma can also look like problems in development or behavioral problems. I think there is sometimes like a poor understanding of maybe the role of genetics. I mean, I think people might think that, well, because the parents were a certain way, maybe the child is headed that way. And it's more complicated than that. And the environment has a great deal to do with the presentation that you see in children.
Part of our challenge is to look at these problematic or difficult behaviors as coping responses, really. They're representing the child's best effort at coping with a very difficult life circumstance. And in many ways, these responses are adaptive. So, for example, if you take an adolescent that's grown up with a lot of community violence, he may physically assault a peer at school for threatening him or disrespecting him. And while doing that might get him suspended or kicked out or some sort of criminal consequence, he's also earned respect from his peers, and he's also proven that you can't mess with him. So if you grow up in an environment where violence is the norm, and it's just part of everyday life, you no longer start to think about that as unusual. So if somebody says to you, have you ever been physically abused? Well, no, I'm hit every day.
So while sorry, Cassie, do you have anything you want to hop in with?
No, I noted a comment in the chat, which I will circle back to. I just wanted to say one just quick thing about my comment earlier about the different range of symptoms before you talk about the factors that protect. And I think what in and of itself, I saw the reaction that, right, many teenagers can have those outbursts and they may not be trauma. So we're not in and of themselves, if somebody has one of these things, we're not saying to say, hey, that could be trauma. But I think if you see this constellation of symptoms or responses that maybe kind of fall across these different domains that we've been talking about, I think that's maybe kind of, and you don't yet know about trauma history, I think that's an area to kind of sort of piece together. And again, not necessarily say this means this, but to be curious and try to start to connect the dots. That's a term we use a lot in this film and otherwise, connecting the dots in your own mind, how these can be potentially a constellation of trauma responses.
Yeah, so while, a lot of the content in that clip so far has been pretty heavy, the good news is that not all potentially traumatic events lead to trauma reactions. Millions of children each year are exposed to potentially traumatic stressors, and only about 30% of these youth will go on to develop a clinical syndrome involving significant emotional, behavioral, cognitive, social, and physical symptoms, which we think of as PTSD. So we know that youth are at greater risk for developing trauma reactions from traumatic stressors if they're younger. This could possibly be because they have fewer coping abilities or cognitive abilities to even kind of understand what's happening. If they have poor support systems, this could be poor support systems both with inside or outside of the home. If they've experienced previous traumas, the more traumas a person experiences, the more likely you are to eventually overwhelm their kind of capacity to cope with traumatic events. And this might be particularly significant for young children because, as we talked about a little bit earlier, early trauma puts a child at a greater risk for future traumatic experiences. And youth are also at greater risk if they've experienced interpersonal trauma, as Cassie was talking about before. So when those caregivers the child relied on to take care of them kind of violates this biological agreement that we have to care, by harming them, a child can become severely wounded and kind of have this sense that there is no safe space. On a more positive note, trauma reactions can be buffered by resiliencies that youth might either have internal to themselves or external in their environment. And these can include things like having a good temperament, having different competencies, skills, or gifts, different strengths that they might have, community support, both from mentors or other folks in the community that might help them with coping with a traumatic event and give them safe spaces, and a spiritual belief system. So while this presentation is focused on understanding complex trauma and some actions that you all as providers can take, we also believe that it's super important to touch on the ways in which trauma work can affect you all. We found in our other presentations that provider experiences of trauma are either admitted or touched on very briefly at the end. And we've placed this here to really emphasize its importance, even though we only have time to touch on it quickly, given that this isn't a secondary traumatic stress webinar. So we think of these provider responses to trauma as secondary traumatic stress, or STS for short. And this is in response to listening or being exposed to traumatic or stressful experience of others, particularly if it's in a repeated way, as it would be if this is part of your job. And the symptoms of it can really look quite a lot like PTSD. And we feel that it's not just important, but essential to educate and discuss secondary traumatic stress and its potential impact. Anyone who engages with and inquires about trauma, like you all do in your jobs, is at risk for experiencing secondary traumatic stress simply due to that exposure of the story or experience of another. As a professional, if you can pay attention to the possibility of secondary traumatic stress, you not only have the advantage of being aware of it in yourself to possibly mitigate reactions and also identify them when those responses might emerge, but you can also become aware of how your possible reactions could impact the work that you all are doing. So what does secondary traumatic stress look like? We think about it as falling kind of within 3 overall categories, which all stem from difficulties either managing your emotions or struggling with meaning. These can include psychological signs, changes in relationships, and changes in behavior. These might not all happen at the same time, and not every person's going to experience every part of these. And some common secondary traumatic stress symptoms, which again very closely mirror PTSD symptoms, are hypervigilance, always kind of feeling on alert or on edge, hopelessness, avoidance of clients or just other folks in your life more generally, anger and cynicism, sleeplessness, chronic exhaustion, physical ailments, and feelings of guilt. So now that we've given this super brief primer on what secondary traumatic stress can look like, I want to introduce how we can begin to proactively and or responsibly engage in self-care. To offer a brief but important introduction on how we can prevent and respond to secondary traumatic stress, these kind of ABCs of self-care offer a simple acronym to help you easily remember what to consider when engaging in self-care and how to prevent yourself from developing secondary traumatic stress or mitigate its effects if it's already developed. So awareness, determining how you're feeling, what your stress level is, and what your behavior, and whether your behaviors are consistent with your values or who you want to be. This can come in the form of finding ways to check in with yourself, see how you're doing. For some folks, this can come in the form of a reflective activity like journaling. Balance, so finding balance among different types of activities, including work, personal, family life, rest, and leisure. This can include something like not having your work email on your phones. So when you're with your family or engaging in leisure activities, you don't have the temptation to check in on work and get exposed to additional stressors. And connections, building social connections and supportive relationships with coworkers, friends, family, and community. This has obviously been harder since the start of the pandemic, but finding ways where you can to remain connected to other people in your life and community. How this has kind of come about for me during some more stressful or COVID affected times is manifested in a group chat where there's just a group of folks who also work in the mental health field where we just send like an emoji a day as a way of kind of checking in with each other and seeing how each other's doing. So now I'll pass it back over to Cassie, who's going to talk about trauma and misdiagnosis.
Okay, thank you, Patricia. And I was just responding to a couple of things in the chat as I was able to, but we will definitely circle back, as Kara said, during the Q&A portion. So one of the things that we've touched on a bit is this issue of diagnosis and potential for overdiagnosis or misdiagnosis, which is definitely a common thing, unfortunately, for young people and youth who are impacted by complex trauma. So if you wouldn't mind going to the next slide, Patricia. So one of the things that we've tried to talk a lot about is how there is a potential for misdiagnosis or mislabeling for youth who have more of these complex trauma reactions or symptoms. And so one of the things that we know is that children who have, there's kind of a twofold issue here. One is that kids who have a lot of different responses, like the ones you saw in the earlier slides, can look like a lot of different diagnoses, right? So they may look like attention deficit hyperactivity disorder, depressive disorders, oppositional defiant disorder with the angry outburst, the kind of argumentativeness piece, conduct disorder, reactive attachment disorder, we know is a big one. Oftentimes psychotic disorders with some of those symptoms that may be mislabeled or misunderstood, or even legitimate psychotic symptoms. So this is just kind of a list of things that we might see in kids who have these range of responses. And two things that I would say here. One is that this potential for misdiagnosis or overdiagnosis might be more likely if a trauma assessment is not conducted. Because one of the things that we do know, even if a youth or a young person or a child has true PTSD symptoms, if there's not a trauma diagnosis that takes place, these can often mimic other biphasic disorders like ADHD, like bipolar disorder. So we've seen kids who have been diagnosed as bipolar or ADHD who may in fact have PTSD, but not be properly diagnosed. But the other thing that we know is that with complex trauma, that kids can actually have a lot of different presentations and a lot of different disorders. And some of them may be true disorders, but some of them may just be, we've seen kids in our system, in our child welfare system with 7, 8 diagnoses, unfortunately, and that's pretty common. And if you wouldn't mind going to the next slide, Patricia, and I think part of the issue is that there is not one diagnosis for complex trauma. There's been a lot of movement in that direction. And you may have heard about developmental trauma disorder. So when I was working in Boston at the trauma center, I worked with some of the developers of this, the original developers of this diagnosis, which has been proposed for DSM-5. Unfortunately, there was a lot of politics around that. It did not get included, but there are field trial testing currently underway with the oversight by one of my close colleagues, Dr. Julian Ford, and a lot of folks in Boston as well. So we know that there is a way to capture these multiple effects of trauma. And we hope that if this diagnosis makes it in, it might reduce some of that overdiagnosis. But you'll see some of these are the main clusters of symptoms around developmental trauma disorder that are capturing some of the key areas that we've been talking about in terms of affective or emotional dysregulation, somatic, behavioral, cognitive, relation, and self-attribution, which also mirror the domains of complex trauma. So that's all I'm going to say about DTD at this point. But I think the key that I want to underscore is that the importance of screening and assessment is a first step. And we've done a lot of work in that area. And Kara, one of the things I realized is that, and I could upload this as a resource, is that we actually put a lot of work, and we recently just published a monograph through APA on trauma-informed assessment and a guide for clinicians. So if that would be of use, I can share the link for that as well, because we put a lot of work into this frame, using a complex trauma framework. How do you do this from the beginning in terms of screening and assessment? So I think that's all I'll say there. And then we might be showing a new clip now. Okay, yes. So now let me kind of circle back to the film, because we also talk a lot about misdiagnosis and mislabeling. So in this film, so when we created this film a few years ago, we really wanted to do it as a way to raise awareness about how complex trauma reactions can be mislabeled or misdiagnosed. We also wanted to talk about the importance of comprehensive assessment as a way to connect the dots, as a way to communicate and share information across systems. We also, as Oscar Donoso mentioned in the clip before, that importance of understanding not only a child's history, but family mental health history, biologically based disorders, but we also know that those can mask the role of trauma. And so even though those things may exist, trauma can also be present. So how do we really understand the complexity of responses? And how do we understand, even though treatment, there may be different ways of treating youth, and we know there are a lot of different interventions that you can utilize, but if you don't use a trauma framework or a trauma lens in that approach, whatever approach you're using, this may not fully support the youth recovery and may in fact be detrimental in some ways. So I think that's important to note. And as far as misdiagnosis, I mean, one of the things I just wanted to note around that we've seen is, and I have specific examples too in my training, where you do an assessment, you see these responses that can look psychotic. Like I actually worked with a young girl early in my training who had some bizarre like behaviors, and this is before I was quote trauma informed, and putting the trash cans on her heads, doing these things that were bizarre. And at the time, she was treated by an adult provider when she came into the system, who medicated her on Haldol, and she was an 8-year-old girl. So what happened then, she had a psychotic disorder diagnosis, and you can only imagine kind of, then she had that with her. We thankfully, the assessment that we did caused the other providers to take a step back and say, wait a minute, this is not what we think. And in fact, there was active domestic violence happening in her home that others weren't aware of. So we were able to kind of have a fuller understanding of that, take her off the meds, and shift the course of treatment. So that's just one example about how, if we understand things and really try to find ways to assess and understand how trauma may be impacting the child and family, that can really shift the course of treatment. So with that, I think, I just want to say one more thing about the film before we show the clip. And as a few of you have pointed out, in the next slide, thank you, that trauma has no boundaries. So we know that it's prevalent across classes, races, religions, class and other aspects of culture. We know that experiences of complex trauma are often compounded by systemic trauma, racial trauma and oppression, sexism, heterosexism, and other things that oftentimes youth who are coming into our services have. We say that here because we also, if you see Remembering Trauma, we're not going to show the narrative film. We realize that we unintentionally perpetuated some of the stereotypes around families of color who may be more impacted by trauma. And that's not what we wanted to do, but we also saw this as a learning opportunity, how there are a young family, a young boy in the film you will see if you watch the film, and may have perpetuated some of those stereotypes, but it also can be an opportunity for discussion and around some of these, how racism and discrimination can truly impact and compound the impact of complex trauma. So I just wanted to note that there. So I think our next thing is to show another clip around this misdiagnosis issue. Okay, thanks, Patricia.
I think the potential for misdiagnosing trauma or the effects of trauma as something else are quite large, especially with children and adolescents. One of the things about trauma, I think, is that the reactions to trauma fluctuate. One day a child might look very, very subdued and withdrawn and appear depressed or even developmentally delayed, and another day they might look out of control and hyperactive as though they had ADHD. Our biases as clinicians come into play here. So certain individuals may have more experience working with one diagnosis or another, may have more experience with children who have developmental problems, who have bipolar disorder, and so those biases may cause us to sort of see the thing that we're looking for.
When people hear the word trauma, they think about PTSD, but really it extends way beyond PTSD. And in fact, if you look at the research, about 70% of people that have experienced a traumatic event don't actually go on to develop PTSD. Many of them experience difficulties, cognitive, behavioral, emotional, physical symptoms that extend beyond that. And a lot of those symptoms oftentimes are consistent with other diagnoses, including ADHD or bipolar disorder. So there can be some confusion. And what ends up happening is that a lot of these children are receiving multiple diagnoses. And in addition to multiple diagnoses, what often goes along with that are multiple treatments and multiple medications, each treating very disparate kinds of things. So when you look at the symptom picture, you're seeing lots of different symptoms, and so you start treating these different symptoms as if they're not related to one another. So you might be treating the bipolar, or you might be treating the borderline personality disorder, or the ADHD, and people aren't really looking at the entire clinical presentation through a trauma lens.
I don't know what's wrong with me. I get really angry sometimes and nothing can calm me down. And I've heard it all. I have conduct disorder. I have bipolar disorder. There's probably not much you can do to help me anyways. But people keep asking me what I'm gonna do about it. And I don't know. I don't know what I'm gonna do about it because I can't get any help anywhere. And I've tried all the different meds. And the fact is that they just kind of numb me out, but they don't really help me get over anything.
One thing that is quite common to see in children presenting for mental health treatment, especially if they have already been in treatment or in the system, is that they may be on 1, 2, 3, sometimes 4 medications at the same time. The psychiatrists and the pediatricians treating these children are trying to help them. And so when one thing doesn't work, they try something else and they add another medication, and so there's an accumulation of attempts trying to figure out what can we do to help this young person. And so as children go into adolescence, this problem is exacerbated. As they get older, they've seen more and more different clinicians, and possibly more medications have been added. One of the things that I like to think about in practice is if someone comes in on several medications, that begs the question, why are they on them? And perhaps they're not working. And if they're not working, that may be because we are not treating the right thing. And we need to take a step back and sort of widen our lens and say, maybe if we take some of these medications away, we can try to figure out what is actually going on. Certainly for families, for parents, it might be much easier to think that your child has a biological illness rather than that your child has been exposed to things that are so disturbing and so profoundly affect every aspect of children's lives. For parents, that's not easy.
When we see kids with multiple diagnoses, depending on the system that they're in, those diagnoses may be actually treated in isolation without the common thread of trauma. Oftentimes, these youth move in and out of systems because of the different diagnoses and labels that they receive. So, for instance, we may see youth having aggression, having substance use, having problems with oppositionality, and those in and of themselves can have individual diagnoses and often lead to the labels of being a bad kid at school, or being labeled as delinquent, or ending up in special ed services when they may or may not need that for their academic or learning difficulties, ending up in the juvenile justice system. And so what often happens as these kids move in and out of these different systems and have these different labels, those labels get carried with them to the other system that they move to. And then the child themselves may actually have an understanding of themselves as being a bad kid, as being a troubled kid, versus really having a true understanding of what may contribute to those difficulties. And I think that's oftentimes the fault of us not having a trauma-informed system of care across the board.
Thank you, Patricia. And we want to get your reactions to the film in a second, but just to quickly, I don't think this slide is necessarily needed, but this is just kind of a reminder, it's kind of restating what we already have said. There's this maze of diagnosis or misdiagnosis that can often be the case with a lot of potential for comorbidity. But I feel like every time I show the Remembering Trauma clips, it's pretty heavy and you see some of the narrative pieces. So we want to give you some time to kind of react, respond here. And we'll take about 5 minutes before we jump to the next section. So yeah, what are any initial thoughts you have about the video, the clip, or comments or reactions about the material so far before we move to the next section? I see, Helen, a question from you. Examples, are you asking for examples of trauma-informed care? We're actually going to be moving to that in the next section about examples of trauma-informed care. Okay, thank you, extremely moving. Yeah, and there's two parts. When we go, Patricia, if you wouldn't mind going to the next slide for a second, there are two parts to the film. Sorry, not there. Yeah, so, and there's a lot of resources associated. So we're showing you parts from part 2, which is the expert commentary. But if you haven't seen the narrative film, it's 16 minutes long. It is really moving, and we're very grateful that we work with a wonderful director. Actually, for those of you who have seen Removed, the short film by Nathaniel Matnick, he worked with us in creating these films. So lots of great resources, and rememberingtrauma.org, we have a lot of these resources, specific questions if you want to use these in the context of trainings, and they're free of use on YouTube as well. Let's see. Yeah, so I see comments around, Patricia, I don't know if there's any you want to feed into the mix here.
Yeah, just a lot of reflection about different youth that they work with as being mislabeled as bad or having a lot going on or being disruptive. Meanwhile, there might be trauma at the root of it, and people wanting to be conscientious in their own work about labels and diagnoses and the amount of medications that youth are on.
Mm-hmm. Yeah, And I think if you see the film, we were, and this is thanks to our work with our filmmaker, but we were deliberately a little bit provocative around some of the messaging, because we really wanted to push the envelope. I mean, with this young, you see the depiction of the young boy Manny, and then him and his an older teen / young adult, and how he had multiple labels, but then you see the context of, you know, what he experienced, what he witnessed, and then at the same time, a provider in the school saying, you know, is it ADHD? Is it something developmental? Is it all these different things? But then you see it in a very, you feel it in a more profound way when you see everything that he experienced. And it's obviously so much about his context and his environment, and how just really trying to push that, like how it's so important for us to kind of question and be curious and connect the dots when we see these reactions that may look like other diagnoses.
Yeah, there was also a note that from Scott Smith that children often have trouble expressing what's troubling them. Therefore, all behavior is communication.
Yeah. Yeah, that's a great point. And just in terms of, I see, Royal, your comment about medication. One of the reasons, so Kat Scott, the one we're speaking to, is a psychiatrist. And then one of the things I know, at least from working in Illinois for many years and other systems, that that psychiatrists are hard to come by, period. And working with psychiatrists who are also trauma informed. So her perspective is really valuable, I think, in this film too, is that, you know, how providers, you know, can, you know, who treat, who prescribe medication can take a step back and really kind of look at, you know, the whole picture around that. And it's, I know medication is a challenging issue, right? But how do you then kind of support some of these other issues, or even just kind of understand that more fully? Yeah, I see a lot of comments around medication. Okay, we had a good juncture, so let's just wait another minute. I don't know, Tricia, if this is a good juncture to transition, or if you want to kind of wait and see if there's any more. Yeah, finding the right medication. Mm-hmm.
Yep. And then I think we just had the poll about the use of it. If you
oh, right. Yes. Oh, right. Yes. So yeah. So let us know. I mean, and these are all free resources, but if this is something that you can see yourself seeing, or not sure.
Yeah, and I think as folks are taking a moment to answer that, we can kind of move on to the next section, which you all kind of alluded to already. But now we kind of want to focus on what you all can do as providers with your own work to use your knowledge and your skills to support trauma-informed practices across the different systems that you work in and youth that you work with. So we want to discuss how to help children heal from trauma. As an NCTSN resource states, some children, if given support, will recover within a few weeks or months from the fear and anxiety caused by a traumatic experience. However, some children will need more help over a longer period of time in order to heal, and may need continuing support from family, teachers, or mental health professionals. So it's looking like too, you all are saying that this could possibly be a good resource to use with the folks that you're working with. So in thinking about this, providing this support is really where you all come in from the variety of roles in which you hold. So some general guidelines about how to effectively provide that support may include recognizing that exposure to trauma is often the rule and not the exception for many of the youth in the settings that you work with. Recognizing and being aware of the cumulative effects of trauma, some of which we discussed earlier, and how they may look different at different developmental levels. And realizing that an individual's behavior that we might think of as bad, might be an adaptation to trauma or a result of not developing age-appropriate emotion regulation skills due to the way that trauma may or may not have impacted their development. So some additional recommendations for trauma-informed practice include routinely screening for trauma exposure and related symptoms, conducting a comprehensive assessment, gathering information on a range of traumas, reactions, and strengths. And importantly, thinking about doing this maybe not just at intake, but periodically too, if you're working with youth over an extended period of time. Integrating culturally appropriate and responsive evidence-based practices. So realizing that it's not going to be one size fits all, you're going to have to adapt some of the things that you're doing to the individual youth and different aspects of their culture and different strengths that they might have. Engaging in efforts to strengthen the resilience and protective factors of children and families and adults impacted by trauma. Addressing caregiver trauma and the impacts that it might have on the family system. Enhancing communication and sharing resources with youth, adults, and providers on trauma and its impact. Promoting effective family involvement in counseling services. Emphasizing the continuity of care, collaboration, and training for all professionals across the different systems that you work with. So maybe thinking more broadly beyond just the counselors in the setting, but all different adults that the youth might interact with. And maintaining an environment that addresses and minimizes secondary trauma and increases staff resilience. So we really have to think about caring for the people who care for the people. So now, Cassie, I'll send it back over to you.
Yeah, so we kind of decided, Kara, last minute, we wanted to insert one more clip because we thought this was relevant given the nature of, that most of you are behavioral health providers. So just kind of reinforcing some of the messaging we've already started to talk about assessment and treatment. It's a quick one here.
As to what makes someone in my role trauma informed, I would say that it's to always have in the back of your head a question about, has there been trauma in this scenario? Is there something that I overlooked? And to never stop asking, not on the first assessment, the fourth assessment, the fifth assessment. Sometimes what can happen is that somebody writes down in a chart, no history of trauma. There's no history of violence. There's no history of sexual abuse. And the next person who comes along sees that in the chart and says, oh, I don't need to ask this question. It's already been asked. So to never stop being curious and to never stop trying to really understand whatever the story is behind the people that we see in treatment.
A lot of clinicians are just uncomfortable inquiring about trauma experiences because it gets into asking very difficult questions, or they might be mistakenly think that they're going to do more damage if they ask questions related to trauma or trauma experiences, or sometimes they just minimize the impact that trauma can have on a child's development.
If trauma goes unassessed, and if the services that are provided are not trauma informed, and if family members and caregivers are not getting feedback on how the assessment process went, what the value was, then we're actually doing a disservice to them. So I think the more that we really not only engage our providers, other professionals as partners, but the more that we engage our youth in the process of providing good trauma-informed services, the more that we engage our caregivers in that process, the more effective our services will be and the more meaningful that they will be in the long run.
Whenever we go into assessing, you always want to broaden your perspective and consider other options. If you don't ask that one important question, why? Why is this child inattentive? Why is this child having difficulty with his peers? Why is he blowing up at people? Then you don't know. It's entirely possible that he does have ADHD and he does have bipolar, or maybe it's purely a trauma response.
Thank you, Patricia. And I think as we close this out, I just want to kind of highlight a couple of additional recommendations. And given that, our work, I was trained as a clinical psychologist. Patricia's being trained as a clinical psychologist. This is our background, but a lot of our work that we do, as I mentioned at the beginning, is with multidisciplinary providers. And so while we're not talking about treatment per se here, we'll kind of show you a slide at the end of some of the best practices treatments, but we know that all providers, regardless of your role, can have an impact and can intervene with young kids and families impacted, or kids and families impacted by trauma. So these are just some general tenets that we like to keep in mind. How we can be a historian for the family. How do we kind of gather the information and share it back with the family, kind of be transparent with them, remain calm when confronted with these details that can be horrifying, disturbing, but that's going back to what Patricia said earlier, the importance of self-care and your own self-care as you kind of are faced with these things, but how we are present with the family, with their experience is really key. How we can communicate to them that they're worthy of love and care. And you'll see that illustrated in the next video actually very beautifully by one of our providers that we work with. developing authentic relationships is critical in whatever provider role that you're in, with young adults, with youth, and working to build strengths and competencies. Sometimes we often get very deficit focused with all of these diagnoses, but how can we also support strengths and building those strengths in whatever work that we're doing? And as a provider, advocating for services. So as I said at the beginning, advocating for those services in the work that you're doing with other systems. If you work with child welfare, juvenile justice, schools, really be somebody who carries that message, the importance of using that trauma lens, and how do we support strengthening those ties to communities, other caregivers as part of the strength building process. And then finally, supporting and honoring youth voices and experiences. And I think this last, if you wouldn't mind going to the next slide, Patricia, this is something we've done a lot in our work with the young adults, and I'm so excited and proud of this film we're about to release within a couple of weeks, focused on transition age youth, which are young adults who are transitioning out of systems, child welfare and juvenile justice in particular. That's been a big focus of our work in this grant cycle. If you wouldn't mind going to the next slide, and then this is a new resource we've developed, which is documentary film clips with young adults in systems that's really focused on amplifying their voices and their stories and hearing from them what we as providers need to do differently. And while the focus of our presentation wasn't on transition age youth, we thought this would be a compelling clip to end with, because they really offer some important strategies and suggestions for providers and how to support youth in a more trauma-informed, strength based, and I think racially just way in the way that we do our work. So Patricia, if you wouldn't mind just showing this brief clip, these are two young adults that are featured in this film. Actually, many of these, you'll see young adults who we were very, very fortunate, and I'm so humbled by the opportunity that we were able to film them and ask about their stories while they were in the Santa Barbara County Jail, and some of them who are child welfare involved, some of them are juvenile justice involved. These are some of their messages to providers.
How can probation officers get more of like why people do what they do? Teachers. Yeah, teachers too. Like your teachers inside there. Like I know that like in juvenile hall, if you say something, you get kicked out. Like, and that's like taken away from your school, and already you're taken away from a setting. Like, how could these people get like? Well, I know you could cuss at me all you want, but I still want you to be in this room because I'm gonna still teach that math problem, and I want you to, at the end of the day, be in here rather than be kicked.
I've seen a lot of staff that used to treat me like crap grow up into like one of my favorite staff because they got close to me, and then they'll talk to me, and then people would think, oh, we need this, we need that, you know, like no, like just support and like showing that you're caring, like it goes a long way. At least for me, it can win a long way.
You know how we all, like people all the time is like, man, well, if I had your job, I would have do this. If you had that job title, what would you do? I just want to send a message to public defenders, you know, like, yeah, you guys, you know, you guys don't know us, you know, but it's someone's life, you know. It's not just, you know, it's not like a piece of trash. It's someone's life that you're dealing with, you know. And the DAs, you know, like I understand it's their job to put, you know, to go against us, but like the DAs don't even look at me. They don't even look at me, and if anything, the most they'll do is point at you. That's it.
A lot of public defenders, a lot of DAs, they are overworked and stuff, but still, that's no excuse. I mean, it's our lives that they're messing with. Our lives.
We need people like you to help us do our work better. There's a lot of youth within our community and in our nation that are really asking for help, but in ways that cause harm or pain to others. Because hurt people hurt people.
When I get out, I'm gonna have my little family right there. So that's like my concrete right there, like my foundation. So that's like I already have a step in the right direction. People that want me to do good. My mom's gonna be so happy right now.
You just keep showing up and you keep being authentic and real with them and focusing on what they're good at, because they have so many gifts and so many talents, and sometimes they don't see it. And so you help them see it. And we can hold up a mirror and we can show them all the amazing parts of themselves. And we can say, look how wonderful you are, and look how awesome you are. And it's uncomfortable for them, you know, it can be. And so we just keep holding up the mirror and reminding them that they're so much better than their circumstances. You know, we always say like, hey, where you start out is not where you have to end up.
Like, ask for help. That's the thing. Search for opportunities. We are not the worst deed that we've done in our lives. Youth that commit serious crimes can change. They're just like everyone else. I'm just like everyone else. I just want an opportunity to do what I can, and I want to be able to reach my goals and my dreams, and I want to be looked at as that we're good and not bad, and we could be good.
You can't change nothing overnight. You have to stay humble and you have to continuously have faith. Those was like my main 3 things that like kept me going. And you don't have to be strong all the time. You don't have to hold that wall up. You don't gotta, you don't gotta be Superwoman or Superman. You could be whoever you wanna be. You could be weak. You could sit back and cry. Slowly but surely, I know I was gonna make a difference. I knew that something was gonna start to change.
Stand up for yourself. If no one else stands up for you, you know what? You stand up for you and just use your voice and say, hey, someone's hurting me. I don't want to go home. We have that power.
For like younger youth who are still in the system, or even for those who have been adopted, I mean, I live by a very hard and fast rule, is that it doesn't matter who gives birth to you, it doesn't matter who raises you, it doesn't matter who pays for you. The only thing that matters is someone who loves you unconditionally and gives you life and gives you hope and gives you support and care.
I'm still smiling, I'm still here, and I'm still trying to keep my head high, and I'm gonna do everything I can to get home. And even though I'm here right now, I'm still trying my best to do good, and I'm still gonna do something with my life. And I'm ready to start my life, and I'm ready to move on, and I'm pretty sure there's people out there that want to start their life too. As long as you have a strong heart, you're gonna do it, people out there, you guys could do it too, It's never too late. You could be 30 years old and it's never too late, you still could do it, So that's all I gotta say, like you guys could do it. So yeah.
Keep asking for help, man. I know it gets hard, like in here, like dude, always keep your head up, man. Always keep your heart open.
IRC control 2499 bus gate, please.
Hey, they're running.
See that?
I feel like I'm getting out.
So you find your case?
Yeah. We'll be here for a little while.
You're looking alive.
Yeah.
Corporal, one returning.
Come on now, bring me now. So my boy. All right, thank you. Come on now. Yeah, man. Praise the Lord. Praise the Lord.
So we just want to end by kind of highlighting this quote from one of our providers, just about the importance of relationships and being authentic and real as providers. So this is kind of a quote from her, just to remind us how we can really elevate the strengths of young people regardless of their circumstances. For those, I see all the comments in the chat, and people always are curious. The 2 young men who were featured there, they're out in the community now, where I just did a presentation with one of them a few weeks ago, and they loved the film as an opportunity to kind of share their story, and they actually want to keep checking back in with us as a way to also keep them accountable and keep them on track. So it was just such a wonderful experience for me to work with them and work with these providers in creating this. So I think with that, I think we're going to pause, and hopefully that was inspiring for you as an ending. I think we're going to pause here for questions and comments.
Sorry, Cassie. There are also just several comments of folks asking for access to the clip. So I don't know if you want to.
Yeah, I can say so. So yes, this was a good chance to preview this. So these are done, but we're not quite ready to share. So Carola, let me talk with you offline about kind of share here, because we have the official clips that we're uploading to our YouTube channel, and we're going to be releasing within the next couple of weeks. And so we want to, and we have, these are 4 different segments to this film, but this is the last part is called Moving Forward. But we have several segments, one focused on child welfare, one focused on juvenile justice, another on coping resilience, and then this one kind of their wrap up comments to everyone. So you can watch them as not a full film, but we intended them as educational resources that could be used widely. So they will be coming out very shortly, within the next couple of weeks. And Kara, I can figure out a way to kind of share them with you, so you could share them with folks on this once they're done and ready to go.
That would be amazing. I'm just so grateful for your presentation and that our audience got to see some of your amazing work. And this newest video just seems just really amazing. So thank you for giving us a little sneak peek. We do have several questions that have come in that I know we don't have a ton of time, but we're just gonna go through and see what we can cover. So to start, I do feel that we need to be careful not to stereotype children with diagnoses as having trauma environmental factors, as there truly are children born who do not have trauma, but do have diagnoses. Many parents feel very judged and misinterpreted. How can we address this?
Oh, that's a great question. So I think you're absolutely right that, understanding that and I think Oscar touched on it a bit, that I think it's important to note that there are true legitimate issues and diagnoses that we need to work with. And Patricia, I know you're working firsthand with young kids now, and I think we take those very seriously, and we understand we need to treat those, and we need to understand that these are real issues to work with. And I think sometimes I have heard that families can feel blamed for the context, and I think we need to be nuanced. I think this is where the communication is critical, both communication in terms of how we communicate things back, but how we are partnering with families too. Again, our role should not be as providers to come in and judge and say, this is, your child doesn't have these legitimate issues or diagnoses, but they do. But then how do we understand what's contributing to them? So I think it's very much nuanced in terms of how we communicate and collaborate. And I think part of our framework has always been like, how do we partner with as a clinician myself, being trained as a clinician, how do we partner with the adults, the youth, as much as we can, and understand how do we work with them versus saying we're kind of doing something to them. How do we collaborate with them and truly serve? I don't know if there's more you want to say to that, Patricia, but I feel like it's so that communication and collaboration and partnership with families we work with is so key.
I totally agree. And I think the only other thing I'll add is just being really aware too that it's trauma if they experience it as trauma. So not coming in with a judgmental lens that bringing your own, bias into it is like, oh, if I went through this, I'd find it to be traumatic. Really only viewing something as trauma if the youth and the family views it to be that way.
Right.
Awesome. Thank you so much. Another question we have that has come up is I work with ages 1 through 8, and I keep thinking that I probably misdiagnosed them. How can I improve that so it doesn't happen in the future?
Yeah, it's a great question. I think screening and assessment is key. We have a lot of tools that we've used, short tools, longer tools. I think having that, like Catherine Scott, who communicated in the video, I think having that curious lens, and even when you see, as the other participant suggested, you see multiple diagnoses. When you see multiple diagnoses and you yourself have an understanding of trauma or that there may be challenges, I think as providers, how do we can't change the system overnight, as one provider just said, right? We can't change the fact that there's no perfect diagnoses. And we can't change the fact that, I can tell myself, being trained in, decades ago, I did not get trained with a trauma-informed lens. And so I had multiple diagnoses. I used ODD a lot. I used conduct disorder less frequently, but I'm thinking, kind of the depressive disorders, the anxiety disorders, and yet without having that trauma lens. So I think even when those things are already documented in there, how do we kind of still connect the dots? Because we can still use a trauma framework regardless of who the person diagnosing is, who and how many diagnoses the child has. How do we go back and connect the dots? And I think even more importantly, translate that back to the family so they understand, yes, we have an imperfect diagnostic system, but let's try to connect the dots together as we understand why is the child responding this way? Why, what can we do to kind of support them and help them understand that a lot of these responses are in fact coping responses. We need to treat them, yes, but how do we understand that so that child themselves can build a better sense of themselves? And because it's such a relief I've seen in teens that I work with, that when they understand, oh my gosh, now I understand why I'm acting this way. I have felt crazy for years. Understand, like translating some of those dissociative symptoms, which can feel so isolating to young people. And now I understand why this is happening to me, and it can be empowering to have that understanding. So I think that's part of the work we can do in translating despite the number of diagnoses.
Wonderful. Yes, I've heard so many times, people have gone through so many things, but they wouldn't say they've experienced trauma until they realize, oh, that's what it's called, right? Um, Kind of to piggyback on that question, somebody is asking, it seems like complex trauma is really also about a caregiver hurting their child in some way, and complex trauma responds to that in some way. How do we work with telling caregivers that what's happening to their child as a result of that? We don't want to tell a parent that they're messing up their child. And that, so any advice around that would be really helpful. People are asking.
And Patricia, I want to pause too, if there's anything you want to jump in on, given some of your recent work. Do you want to start here? Is there anything you want to say?
Sorry, my mouse is getting funky. Yeah, I mean, I think too, viewing the family system as part of the solution rather than the problem, like providing really good psychoeducation, and also like enlisting them as supports and making sure that they have their own support, can be like coming at it from this strengths-based collaborative framework, as opposed to being like, you did this and now this is happening to your kid. Can I think be a very helpful way of going about it. There still will probably be defensiveness and hurt, because that's really hard information to get. But if there's any way to loop them in as, we're going to work together to see how we can make this better for both you and your child, I think you're probably going to get better traction with that, at least in my experience.
Yeah, and I think as you were talking, Patricia, it reminds me there's so many great resources out there. One that I know a participant earlier commented or asked about early childhood resources. There's a great set of resources called the Stories Project, and some of them are geared towards young kids, and some really young kids, and it's in a storybook kind of cartoon format, sharing like how even domestic violence in the home, domestic violence, but also even arguing, which I know for, that can be commonplace, right? A lot of stress happening, arguing in front of your kids, and having that understanding in a partnership, in a collaborative sort of way, how that can impact the child and impact their sense of their own dysregulation when they're experiencing other stresses. And I think some of the ways in doing that too, in humanizing it. I mean, I use a lot of personal examples in a boundaried sort of way, but just to kind of share, like, this can happen. Like as parents are stressed, there's so many layers of stress that we're experiencing. But from a child's lens, how does a child take that in? And that's just something we all need to be mindful of, because we're all facing a lot of stress, especially over this last year.
Yes, thank you. And my amazing colleagues that are participating today, as in this webinar, have reminded me that family peer advocates are really helpful in helping families during these challenges. So thank you for that. And somebody else also said, often many have the preconceived notion that parents are the cause of trauma. However, there are many instances where the very system that is supposed to help the child is what has caused the trauma. And that unfortunately is true. So thank you so much. I have another question here. I work with an adolescent boy who has been a witness to domestic violence for most of his life. He's 14. His dad has tried to kill his mom, and he has been labeled as having conduct disorder, but he clearly is traumatized now that I think about it. So any advice about my best way to proceed with him? It's a big question.
Yeah, no, it's a great question. And in fact, and that's a good example of how there may in fact be conduct disorder types of symptoms, which could be, aggressive kind of responses to what they've experienced, what they witnessed. And there's a lot of, I think, clearly a lot of trauma. So my first question would be, is there, have assessment or screening tools been used to understand? Because I feel like those can also be an entree. When I did screening and assessment firsthand, I often use those as an entree to the conversation, and whether or not I was kind of sticking to the testing protocol, I always felt like they were an important first step to engaging with family members. So we're going to just kind of talk about some of these things and how they may have impacted your response. And then as a next step, translating those back and helping family members connect those dots so they see. And it may be, I'm not sure what the particular case is here, but I'm not sure if it's a provider that is working directly with the child or someone else. And I would say, Kara, I'm sure you have access to a lot of trauma-informed providers there, but I think helping providers to kind of understand that those two, if there's an assessment tool they can use to help connect those dots, but also how do we, despite if the diagnosis is accurate or not, how do we then communicate that to the child, communicate that to the family that, even though there's this diagnosis, these are the kinds of things that we need to work on to support addressing the trauma that likely impacted this diagnosis.
Thank you. Thank you so much. We have one last question that I'm going to actually kind of end with and share that we're going to have a resource that we created here at CTAC based on our own work around complex trauma. And then you all, Dr. Cassell and Patricia, you're going to also send around the article around trauma-informed assessment. And I think that those two things would be really incredibly helpful. This statement, more of a statement than a question, but there is a question at the end. This is great information about complex trauma and developmental trauma. The thing that is frustrating to me, and I know to others, Sonia, is that people seem to think that manualized treatment is the best way to go, but I find that they're geared more towards single issue traumas. Do you have thoughts about manualized treatment? And so as you begin to answer, I'm going to share my screen and pull up this, this resource as well.
So that's a large question, but I'll answer it quickly because I was actually, one of the debates I often have with my colleagues is that I was trained in a complex trauma framework. So I was trained under Bessel van der Kolk. I was trained using more of a framework approach to complex trauma. So even though I truly support the value of manualized treatments, we also know that there are limitations when working with manualized interventions. And my colleagues who have developed trauma-focused CBT, which is the gold standard, have done a lot of adaptations, modifications to support complex trauma. There are also some wonderful approaches that are less manualized. The ARC framework, attachment attachment regulation, self-confidence, Sparks intervention. We have and at the end of our presentation, we have a list of you have them down here too, Kara, thank you. Real life heroes. There are a lot of different interventions which are much more adaptable, framework-based. Some of them are definitely kind of manualized to some degree. Some of them are more frameworks, but a lot more flexibility given the complex trauma presentations, because I think manualized treatments per se can be challenging at times with complex trauma.
Yes, thank you. I was going to say NCTSN does a great job of outlining some of the really incredible manualized treatments that you all may want to check out, because I agree with you that manuals aren't the answer. In this case, there are some really amazing treatments that have been developed and we just don't really know about them sometimes. Strengthening Family Coping Resource is a fantastic treatment. All of these are really, really great treatments that NCTSN recommends to treat complex trauma. And I think that they're really worth checking out. So thank you so much. do you have other slides you want to bring up really quickly?
Oh, do you want to show that ending slide? But I think that's the same thing. I don't know if we just want to
resources and
our thank you.
Going to wrap up.
Yeah, so those are. Yeah, so these are some of the ones that also similar to what you have listed, Kara, and I think this is the link at the end. If you want to explore further, there's some fact sheets specific to these different interventions. Yeah, and IT, CTA, Integrative Treatment for Complex Trauma, another wonderful resource. TFCBT as well. I think that's often appropriate, but I know, and again, there's been a lot of great work in terms of how it's been expanded, adjusted. So TFCBT, I wouldn't discourage you from that because it's a wonderful intervention. Still CPP for young kids, child parent psychotherapy. So these are some great ones to check out. And it says, can you please share the link in the chat? That's a good
we're gonna upload the handout to accompany this. And if you go into NCTSN, there are these amazing resources as well.
Yeah, and we have a couple of others. I saw that person asked about the Stories Project. It's actually the official name is called Inside Him, and I could send the link to that as well, Kara, because that's specific for younger kids.
Wonderful. Thank you. Thank you so much again to both of you. This is fantastic. I just want to share some upcoming events for our last, well, we're over time. I'm so sorry, everyone. These are upcoming events on, schools as racialized spaces, how to talk with young people about race. Next Thursday, October 14th, identifying and treating self-harming behaviors among youth using technology and social media, Tuesday, October 19th. Join us there, everyone. Hope you have an amazing day. Thank you so much again to you, Dr. Cassandra and Patricia, and I really hope we stay in touch.
Thank you so much. Thank you, everyone. Take care.
Bye-bye. Thanks so much.